We will begin our event shortly. If you want to register to hear this event in Spanish, please go to the Zoom link that is being shared on our social media channels now. En breve comenzaremos nuestro evento. Si quieres registrarte para escuchar este evento en español, haz clic en el enlace de Zoom que se está compartiendo en nuestras redes sociales. Las instrucciones sobre cómo entrar a la interpretación en español se están mostrando ahora mismo. Good afternoon. My name is Rodrigo Stein. I am the Director of Health Equity at La Clínica del Pueblo, and it is my pleasure to welcome you to our La Clínica Talks speaker series. Just a few housekeeping notes before we begin. This is a live event with simultaneous interpretation on Zoom. As such, we remind our guests to speak slowly. That way, our audience will benefit from what you have to say. We'll have a space for Q&A, so encourage audience members to enter your questions in the chat at any point during the program. La Clínica Talks is a space devoted to engaging and promoting healthcare as a human right for Latino immigrant communities in the DMV. By featuring key stakeholders, we try to bridge the gap for constituents and illuminate the barriers and challenges our community members are facing in accessing healthcare and other essential services. It is our hope that this space can illuminate and bring a unique perspective on what immigrant health equity means and the steps needed to advance it. Today's conversation is built on multiple perspectives, including a short video of La Clínica's partnership with the Bridging the Gap initiative. These perspectives have one overarching goal: to increase health access to those who have been excluded. Today, not only do we recognize World Diabetes Day, but we also launch our campaign, Salud Sin Barreras, Health Without Barriers, to promote and guarantee care for the people living with diabetes. Before introducing today's speakers, we will show a short video created in partnership with our guest speaker, Dr. Monica Peak, and the Bridging the Gap initiative.
La Clínica's patient population is primarily Latino immigrants. Almost 90% of our patients identify as Hispanic origin. 85% of our patients do not speak English as their first language. We serve a large chronically ill population. Hypertension, diabetes, and HIV are our top diagnoses. Addressing the social determinants of health is not just a good thing to do, it's the only thing that we can do to be able to achieve the health outcomes that we all want. Frequent barriers that La Clínica Pueblo patients experience are health insurance access, language access, culturally competent care, affordable housing, legal services, food access. Having a safe space where people could come and get services in their own language from members of the community or providers that understood the context which they came from was really the main reason to create La Clínica in the first place. My hope is that we'll be able to resolve the health access for immigrants in this country and understand that public health doesn't work if it doesn't work for all. Bridging the Gap lets us bring our work around community health promotion, wellness, integrated team-based care, learning, education, and cultural competency together. And we have also been able to integrate more screening around social determinants in a standardized way. My hope for the future is that our health sector will continue to evolve in the direction that it's going in its best form, which is to understand that health is not just the absence of disease, that health is broader than healthcare, and that to produce health, we need to address not just what happens in our body or even in our local environment, but the structures that we create to live, work, and play.
Our speakers today are well suited to guide us through a conversation in which we question discriminatory structures that have caused so much pain and what transformations are needed within the health sector. Most importantly, they will guide us to imagine a world where we can have salud sin barreras. Our guest speaker today, Dr. Monica Peak, is a professor at the University of Chicago, where she provides clinical care, teaches, and does health services research with a focus on health disparities. Dr. Peak is the Associate Director of the Chicago Center for Diabetes Translation Research, the Executive Medical Director of Community Health Innovation, and the Director of Research and Associate Director at the McLean Center for Clinical Medical Ethics. Her research pursues health equity and social justice, with a focus on promoting equitable doctor patient relationships among racial minorities, integrating the medical and social needs of patients, and addressing healthcare discrimination, structural racism, and the impact on health outcomes, for example, diabetes. In conversation with Dr. Peak, we'll also have our Executive Director, Catalina Sol, and our Chief of Programs and Community Services, Suyana Barker, plus a community member testimony. So, Catalina, Monica, Suyana.
Thank you for having me.
It's so great to be here.
Happy to be here too. So I think we're going to start with Catalina and Monica in an incredibly good dialogue, and then I'll come back later to join, and Rodrigo too.
So I was really struck watching that video, Monica, and how much has changed and how much has remained the same, right? And I think that it's such a pleasure to be here with you, even though I would much prefer to be around that same table at La Clínica as we were the last time in that video. To launch our Salud Sin Barreras campaign. And to me, there's such significance in doing this on World Diabetes Day, which has been, at least in my career at La Clínica, which I've been involved in for more decades than I really want to confess. This ongoing chronic disease where the health disparities, health inequities are all laid out for everyone to see. And I was just reflecting this morning that back in the day, we used to, I used to fill everybody's prescription with chlorpropamide. That was the one drug that everybody could afford, and I didn't know that there were any others. As a young person working at the clinic. And here we've gone through COVID, and diabetes has been such an indicator, such a predictor of disease burden in COVID, and a huge global pandemic, which has clearly outlined everything that we really need to do and what happens when we don't. And yet, we have also realized that without uphill work and intentional campaigns around health equity, especially around the issues and needs of people of color, it's just not going to happen. It's not going to happen even when the worst occurs. So I'm so happy that you're here at this juncture, because we were, of course, so interested in the Bridging the Gap project, because it thought and discussed diabetes from a totally different perspective. That was not just clinical, that was not just individual behavior. And we'd really love to just have you share, how Bridging the Gap comes about and what perspective it brings to diabetes, and, what your reflections are today after and during all of this.
Thank you so much for having me. I'm so honored to be here celebrating World Diabetes Day with you all. You do such incredible work. Bridging the Gap is fortunate to be funded by the Merck Foundation. And you're right, we think about diabetes not just as a medical disease, but also as a social disease, because it's a reflection of so many systems that have gone wrong, for people to not be doing well when they have diabetes, for things have gone right for people to even get diagnosed in the first place. It's not a coincidence that diabetes has a much higher prevalence in low-income communities and communities of color and immigrant communities, and for these very same people to be suffering higher rates of amputations, of complications, of diabetes-related death, and all the other comorbid conditions that run with it. And so we have to ask ourselves, why is this? Why is this? It is not that these people don't care as much about their health. I mean, that is obviously not the issue. And so there are structural inequities in our society that make it much more likely for people to have problems. Your new campaign around not having barriers. There are many more barriers that people have to navigate on their walk to wellness with diabetes or many other chronic diseases, around insurance access, the cost of medications, things that are there or not there in their environment that can help promote wellness. how they are treated in a healthcare facility, whether or not they feel safe and welcome, and haven where people come and I love that place, feel safe and cared for. Not all health care facilities are like that for people who live on the margins of society. A lot of times people feel the discrimination, feel the dislike and distaste, and feel like they don't belong. And so they don't return. They don't go back for a second visit. They don't go and get their medications filled. They don't go and see the specialist that they need to see, and they suffer the consequences. And so there are just so many reasons that people are not living up to their full health potential. And many of them have to do with poverty, which is not equally distributed within our society. And when you don't have the same kind of income, you have to make really hard choices about, housing versus food versus medication, and how to stretch that dollar. And so what we're trying to do with Bridging the Gap is to think about, for people who have chronic diseases, how can we think about all of these other things that affect their health, food insecurity, housing instability, lack of insurance, immigration status, and address some of these while we're trying to make sure that they're trying to be healthy at the same time, because we know that both of these are at play. And so that's part of the reason that we're so excited to partner with organizations, healthcare organizations that already had this kind of passion in mind. They were already saying, hey, this is who we are already. We're already loving our patients and trying to think about these issues. And if we just had a little more support, we could do more. And we can, think a little bigger. We could hire a little extra person to try and take on these challenges. And that's what we're about, is trying to identify new strategies to tackle these problems. We did not know, obviously, when we started out 4 to 5 years ago, that we were going to be hit with this crazy pandemic, which has created the biggest challenge ever for everyone, and has made managing chronic diseases like diabetes so much more difficult when people are having to shelter in place and they're supposed to be outside exercising. They're supposed to be eating healthy, fresh fruits and vegetables, and they're, staying at home and may not have access to some of the regular sources that they have. And so it's been a real challenge, this pandemic has, for everyone, including those who are already living, just kind of struggling to make ends meet. And so it has been an eye-opener for people who didn't already know about these issues. And so in that way, I think it has opened up conversations and opportunities, but it has still been a real challenge for people who are living through the pandemic.
I wonder also, for La Clínica's patient population is mostly an adult population, and diabetes has been, always one of the top 3 major chronic diseases. And people would come to me at different points in La Clínica's history and say, like, why isn't there a special funding stream for diabetes, as there are, through some other HIV, for example, where we have the Ryan White funding community that really advocated. And, really the answer that we always gave was, we need to have a health system that can actually embrace and treat all preventive and chronic illnesses for everybody in the system. It doesn't require a special program. It requires healthcare access for all. And certainly it's so interesting that you talk about the choices that people have to make, because one of the major reasons for us to articulate this campaign around Salud Sin Barreras is this choice that many of our patients have to make regarding place. If they live on one side in the District of Columbia, they're able to have access to a local insurance program that will cover, their just basic access issues in primary care and specialists for diabetes and pharmacy access. And just across the other side on the street of where their neighbor might live, they're in a county that doesn't provide it, and they are really very much at the mercy of the small safety net that we have in place, charity care, just, the whole concept of charity care as a strategy for addressing the health needs for all, I think has just come, really crashing during this pandemic. But, again, it doesn't necessarily seem as if we're picking up the pieces in the right way, So I'm hoping that the Bridging the Gap project has moved the needle. I hope in research and in the evidence base that supports just really supporting these kinds of strategies with our communities. But what do you think?
Yes, I think that we have been fortunate to have a number of excellent sites. We have 8 grantees across the country, like La Clinica, who are all pushing forward in the same direction. So we have a very what we call heterogeneous portfolio. So we have urban locations, we have rural locations, and we have frontier locations where, in Idaho, where they're more deer than people. We have populations that are, primarily from El Salvador, like yours, populations where most of the patients are African American, others where most of the patients are Appalachian white people. And so we have a lot of diversity in where people are living, who the people are, the payer mix, but everyone is doing the same thing, trying to think about these social and structural determinants of people's health that are really challenging, and trying to figure out solutions for them in their regular lives to help them become more healthy for the individual, and how we can change the health system, and how they're partnering with community health organizations, and how we are thinking about making the community, the whole population, healthier. And so with these different groups all across the nation, we're gaining more evidence, we're gaining more case studies to show that this is feasible, that we can do this. And we're going to need these kinds of case studies to be able to show to the moneymakers, to the policymakers, to our legislators, to our local hospital officials, to say this is something worth investing in. And we know that some of our sites have been able to take the wins that have happened over the course of the past few years and say, hey, this is saving us money. We're, keeping people out of the hospital more. We're, saving money, saving lives. Perhaps this is a program that we should keep afloat. And we're planning to meet with some legislators from the Congress in the coming year to be able to talk about what we've learned from the Bridging the Gap program, hoping to influence policy at the national level that can affect everyone. So we're hoping to be able to do good things from the work that you all have been doing on the ground.
And that's so refreshing to hear. I think that, we're just, again, salute you, for the academic partnerships that can really show that, research for action and change in the area of health equity is what it's really all about, So that's something actually that my colleague, who I'm going to invite back to talk with us, Suyana Barker, who is our Chief of Programs and Community Services, has really developed and emphasized in our work is that relationship building, across sectors, certainly in the academic sector and with other sectors in health, to be able to, have our various parts that we need, to prove our
Yes.
model, to examine our model, to question our model, and to really highlight what that change could look like. So I'm just going to take a moment to invite Suyana back to our
Great.
squares.
Welcome back, Suyana.
Thank you. What a great dialogue, you two. I mean, the thing is, I have some questions from Monica that she answered already, so I'm going to have to improvise here.
Sorry, Suyana.
No, but this is the beauty, right? This is the beauty of having a good partner.
Conversation.
Yeah.
Right. I like the idea of having all hands on deck, and all strategies, and the idea of research in action, because you have to have both of those. You have to have action, and you have to have the evaluation. Like, I'm a scientist, but I don't like research for research purposes. That drives me nuts, like, I don't want a paper that's just going to be sitting in a shelf that no one looks at. Like, there's got to be something that's going to happen from it. People who are going to do something with it have to look at this, and We have to be able to think differently from the work that we're doing. We have to be able to move the needle, not just get promoted. Like, what is that? I need my job. I do. I don't want to get fired.
Yeah. Well,
Yes,
thank you,
if it's
Catalina, for
not to
joining
make
us.
our world a better.
Oh, sorry.
Oh, yes, thank you. I am going to step off and listen from the other side, and again, it's a wonderful partnership, and I'm really glad that you could be with us on this very special day. I'll be tuning in, and thank you so much.
Thank you, Catalina.
Monica, I think we lost you a little bit at the end of your, we had some.
Just rambling on about why it's important for research to be important, and why I'm so thankful to be a partner with La Clinica, and to be able to think about the things that you all are doing, and evaluate that and share the findings ultimately with the rest of the nation. These kinds of case studies are going to be what it's going to take to show the world about the kind of work that you guys are doing, and that these kinds of things are possible.
Yeah, and I think the most important part of it is because even though with all this technology, right, we're celebrating 100 years of the discovery of insulin, and we still have people who does not have access to medication, but also technology. So I think as much as we can discuss it or bring this to understanding, right, that some of the, because when you think about science and technology, it feels like is solving everybody's problem, but no, right? I mean, we still have a huge divide that not everybody, and I think you talk about it, right? When you're describing the whole perspective of Bridge the Gap, you bring that, like what is really dividing people is really the structural and social determinants. I don't know if you want to share anything else, another insight that you have around that, if this was one of the questions that I had for you.
I think one thing that a lot of times scientists forget is that every time we have a new scientific breakthrough, that creates the opportunity for more disparities, because the people who will benefit from those breakthroughs are ones who have access to social capital, access to financial resources, those who have access to the hospitals, and and those who don't are going to be the ones who don't have and don't reap the benefits from this new technology, this new medicine, this new whatever. And so some people's health will get exponentially better, while those who don't have access to it, theirs will continue to be the same. And so, we have to think about equity every time we have a new scientific breakthrough, and think about how that can be equally applied to the population. And we think no further than the current pandemic that we're in, and think about the new vaccines and how that has not been equally applied to the population. But we can also think, like you just mentioned, about insulin. That has been around for a century. We are celebrating insulin's 100th year this year. And despite it being around for a century, it is still too expensive for many people in the globe. And even in this country, where it is exorbitantly high, much more high in the United States than it is in any other high-income country, because of our strange way of doing politics and the way that we let them, the big three companies that produce them have just an outrageous monopoly, and we won't regulate the prices. We have priced out insulin for the people who are most in need. And unfortunately, the people who are most often prescribed insulin and who need it most are those who can't afford it. The low income, Black and brown people, immigrants, those who are heavily burdened by diabetes. You get diabetes and suffer from diabetes because you are disproportionately disadvantaged. And then you ultimately need insulin. But then insulin is so costly that you can't afford it. And so it's this strange paradox in this country. And then in other developing countries, the cost of the annual cost of people's income is so low that insulin is more than people's average income. So who can afford that?
And
so,
also we see all the migration flows that when they start that, sometimes we think about migration as just people wanting to go to a place to buy a house. It's much complicated than that, right? We have incredibly the distribution of resources not equal, and then you have sometimes something so simple as I need to go to a place where I'm going to have not only a better life, but I'm going to survive. So the survival that drives so many of the human migration, right, and mobilizing people from one part to another. And that's why a little bit, right, this perspective that we have, that some of the problems that we have are not only in our community, but we should do something about it in our community, is why La Clínica get involved in something like developing an advocacy campaign called Salud Sin Barreras, right? Health without barriers.
Yes.
But some people don't understand that. Some people don't understand why a clinic is doing that. And that's come to, when we think about that, came to a conversation that we had with you once. I don't know if you remember.
Yes.
We are discussing the La Clínica kind of singularity, right, on this pool of grantees on Bridge the Gap. And you said, well, La Clínica should define their model of care as justice informed. Yes. So the just informed care, I wondering if you could tell us a little bit, when this came to you, what is the core elements that we thought? What is a health system that's just informed? Just informed.
Yes, to me, when I think about La Clínica, and you tell me if this sounds right, I feel like what you all are doing is working to create a more just world, a more just space in which your patients are living. Part of that is, being healthier people, and having equal access to resources for them to be healthy. But part of that is for them to live lives that are free of discrimination, and for you all to teach yourselves about what that would be. I remember that you all did in-service training, around Black Lives Matter, even though most of your patients, are, coming from El Salvador. And so, you take all of these issues around the structural determinants of health as seriously as you do clinical care delivery, because it's just another thing that impacts health. Medical care is, only one factor. Housing, poverty, all of those two things alone impact health more than, penicillin and, an hyperglycemic medication. And so all of these things together, you look at health holistically. And so for me, what you all are really trying to do is create a just world. And that justice informs the care that you deliver. And so that's why I call it justice informed care.
Yeah, I mean, for us has been really a struggle to not make our perspective being a perspective of only see what we identify, right, or what we think we represent, but how can we get our struggle and the struggle for our clients and make this for everybody, right? Yeah. I remember once saying that if you have a system who can pretty much serve the most marginalized person, if the system can serve that person, that system can serve everybody else.
That's so right.
I think sometimes we do that. We make the most vulnerable the exception instead of the rule. But I think if we create a system where the exception is the rule in terms of quality, right? What would take for us to provide quality care for that person with that many vulnerabilities? If we do that, the rest is done, right? Some people would not need us a lot. Some people are going to need us just once a while, but those who need a lot would be served. So
that's exactly right.
And we love that. We love when we said that, because I think that kind of dialogue, right, with you all from University of Chicago and from the Bridging the Gap, I mean, the whole cohort is seeing us through other people's eyes, right? But eyes who wants us to get better, right? Because sometimes we get other eyes that are not really, not really good. So it has been very interesting to being able to grow with all of you, because the eyes of other people is pushing us to do better.
Yes, yes. We're a team.
Yep, this is the, we're very appreciative. So I'm going to call Rodrigo back to the next phase of our conversation, because one part of this is bringing also our community here, right, Rodrigo?
Yes, and thank you so much for bringing such important points, such as viewing healthcare holistically and viewing definitely healthcare as more than just the delivery of healthcare services, but all the structures such as housing that need to be in place. However, healthcare access is a social determinant of health as well.
That's
And
right.
many patients at La Clínica who have diabetes don't have consistent access to healthcare. For example, in DC, we have the DC Alliance program, a city-funded healthcare system for those who are not eligible for Medicaid or do not have private insurance. Many who rely on the program are immigrants and receive care at centers like La Clínica del Pueblo. However, unlike the yearly renewal of other assistance programs like Medicaid, recipients have been required to recertify in person every 6 months. These requirements have several barriers, such as lost wages due to long wait times, interruptions in care, accessibility issues due to language and technology. There was some small progress during the pandemic. This requirement was lifted. However, after the emergency, the only change we saw was, yes, we'll drop the in-person recertification, but you still have to recertify twice using technology and telephone systems. This recently caused over a glitch where almost 7,000 people were not able to recertify in this transition. And even though the deadline was extended, it demonstrated the precarity of a system that it does not match equality for all. There's still
Yes.
barriers for a certain group of people who live in the district. So to expand on these issues and to share the story about these barriers and more, we have invited a patient from the community, from La Clínica, and I'd like to introduce Bessie Anaya. Bessie Anaya is a former board member at La Clínica del Pueblo. She has been a resident of the District of Columbia since 1995 and a patient since 1996. Bessie is currently enrolled in one of our chronic disease self-management programs, Tomando Control de su Salud. Monica, I'll ask the following questions to Bessie, and then I'll interpret them back to you. I'll ask two questions. The first question is, what support have you required to manage your diabetes? The second question will be, how have the interruptions in your insurance alliance coverage impacted your condition? I'll now introduce Bessie in Spanish. Buenas tardes, Bessie. Un placer
Buenas
tenerla.
tardes, Betsy.
Muy buenas tardes.
Un privilegio que esté con nosotros.
Muchas
Bessie,
gracias.
conté un
Muchas
poco su
gracias por la
historia,
invitación.
que fue miembro de la Junta Directiva de El Salvador, paciente desde el 96 y viviendo en DC desde el 95. Le voy a hacer dos preguntas, Bessie.
Ok.
La primera pregunta que le voy a hacer es, ¿qué apoyo ha requerido para manejar su diabetes? Y la segunda va a ser, ¿cómo ha impactado en el cuidado de su condición las interrupciones en la cobertura de su seguro, la alianza? Entonces empecemos con la primera pregunta y después yo le cuento a la doctora lo que usted tiene que decir. Entonces, ¿qué apoyo ha requerido para manejar su diabetes?
Bueno, el apoyo que yo he recibido es el acceso mi doctora, ¿verdad? Y también acceso a la insulina, a los laboratorios y a las visitas médicas, ¿verdad? También estar al día con la medicina también para manejar bien la diabetes y sentirse uno bien también, ¿verdad? Y también lo que me ayudó bastante fue lo del programa Tomando Control de su Salud. Eso fue lo que yo sentí el gran cambio en mi vida, ¿verdad? El cambio para tener al día tener controlada la diabetes, ¿verdad? Y también los ejercicios, ¿verdad? Todo me ha ayudado a mantenerme así.
Gracias, Bessie. So for the first question, which was what support have you required to manage your diabetes? I needed access to view a doctor. I needed access for insulin to obtain the labs and the medication I need. All these things have been important, as well as access to programs such as the chronic disease management, Tomando Control de su Salud, where I've learned to control my diabetes and practice some exercises. Ok, vamos con la segunda pregunta, Bessie.
Okay.
¿Cómo ha impactado en el cuidado de su condición las interrupciones en la cobertura de su seguro, la alianza?
Bueno, lo primero es de que perder un día de trabajo, ¿verdad? Para ir a renovar el seguro, ir a la H y llegar a las 4 de la mañana para hacer la número 1, la número 2 en fila, ¿verdad? Para salir temprano. Y también no poder acceder a la medicina por falta del seguro, ¿verdad? Que no me cubre varias medicinas. Yo tengo 2 años de estar comprando la medicina y también el seguro no me cubre varios servicios con los especialistas que tengo, ¿verdad? Porque tengo pendiente el examen de cáncer y el examen de los huesos y me mandaron una carta que no me cubre el seguro. Y también me llegan a facturas, ¿verdad? Que no las cubre el seguro. ¿Verdad? Me gustaría a mí por medio de esta entrevista, ¿verdad? Por medio de mi testimonio, que puedan escuchar la voz de la comunidad y puedan darse cuenta de las barreras que pasamos nosotros, ¿verdad? Por los cambios del seguro, ¿verdad? Y también que haya un cambio para el bien de toda la comunidad que participamos en estas actividades. Eso es.
Gracias, Bessie, por su testimonio. So, for the second question, which was what support, how have the interruptions in your insurance alliance coverage impacted your condition? I lose a day of work just to get to the H Street for my recertification. I have to get up at 4 a.m. just to be the first or second in line, and no guarantee that I'll be seen that day. I don't have access to the medicines I need, and sometimes I have to pay out of pocket just to cover the insulin. The insurance doesn't cover everything I need to have for my coverage. For example, I've lost cancer screenings and exams for my bones. I also have received bills which I cannot afford. And I hope that by providing my testimony, I can expand to eliminate some of the barriers that affect our community and produce some change for all. So, Monica, after hearing Bessie's testimony, does this sound familiar to you?
Unfortunately, way too familiar. It's heartbreaking. Yes, our country does not respect the time and effort of those of us who are low income. It takes away our dignity and shortens our lifespan, as we can see with some of the things that by limiting our access to health, medications, screening tools, and these are not accidental. There's a compromise that our country is always doing. We, on one hand, some of us want to support those of us who are the most vulnerable, and so we have these programs.
Monica, I'll just have to translate that before it becomes too much. Entonces, Bessie, Para Mónica es muy familiar su historia y tremendamente dolorosa. Y tremendamente doloroso que Estados Unidos, este país, no respeta a las personas de bajos ingresos, no respeta la dignidad y la vida y el esfuerzo que desempeñan estas personas. Realmente este país es que realmente daña la calidad de vida, acorta la vida de ciertas personas, limitando el acceso a servicios con especialistas y servicios más específicos como los que usted mencionó. So, Monica, yes, please.
So the part of the country that wants to help creates these programs. And then the other part of the country that doesn't want to help sets all of these extra rules and guidelines and red tape and wants to make sure that no one who might not be qualifying gets through. And so you have to, re-enroll every 6 months, or you have to have all of this paperwork and all of these extra forms and proof that you're deserving of these programs. And part of, I think, the design is that people will give up hope and stop coming. That those 7,000 that were lost through that glitch won't get back on. If the programs really wanted everyone to be served, they wouldn't have you to have to jump through all those hoops all the time.
Excelente. Bessie, ella comenta que ella presenta que una parte del país quiere ayudar, pero hay otra parte de este país que se niega y crea muchas barreras burocráticas para prohibir el acceso y hace todo lo posible para desincentivar, meter miedo y con el objetivo final de que la gente pare de solicitar y exigir su salud. Entonces, y que la gente eventualmente se rinda y deje de exigir sus derechos. Entonces, si algo de verdad lo necesita, es el problema. Entonces, creo que con eso podemos hacer la transición a la sección de preguntas abiertas. Muchas gracias, Bessie, por su participación.
Muchas gracias por invitarme.
Monica, thank you so much for the answer, and thank you, Bessie, for participating and providing that impactful testimony. I think we'll transition now to the Q&A from.
And Bessie can still participating on the Zoom, because now we're not going to do the consecutive actually interpretation. So Bessie can still joining us through the Zoom. And we have questions, right, Rodrigo?
Yeah, I think we have 2 questions so far. The first question I see is from a Spanish speaker in Zoom. Is in the future, will universal healthcare be available for undocumented migrants?
In the present, universal healthcare isn't available for anyone. So we have, we're closer to universal healthcare than we were before. With Obamacare, but it's not universal healthcare. And so I'm hoping that we can continue to move closer to expanding access to coverage for everyone who needs it. These heart-wrenching stories, are not unique, and it's the reason that organizations like yours are so critical and pivotal for communities and for not just in the daily provision of healthcare that you do, but in the, the ongoing advocacy that you do as well. And that's why it's, there's so many of physicians around the country who feel like their only job is to provide care, and they don't really see the importance of advocacy, or think that advocacy is something that is, out of our lane. But you cannot work directly in health facilities like La Clinica and not see the dire importance of that. And anyone who chooses to be in, every statement right there, because you're letting the status quo continue. And so our actions are merely another kind of political statement. We're choosing to try and work against the status quo. And that's something that I think we have to do when we see patients like that. We see the reason for this action. And so I am hopeful that we will one day get to the point where we can see not only the moral and ethical need for everyone. I think that is clear. What's going to take us to get there, I think, is what drives a lot of policy, which is seeing the return on investment, seeing the business case. And that is what I think has pushed a lot of the interest in the social determinants of health. Like, oh, wow, if someone had a house they to go home to, as opposed to living unsheltered, then maybe they won't be coming back the next day with that same, diabetic foot ulcer that, just got worse. And so thinking about how to keep people healthy ultimately is cost savings. Thinking about how to keep, all the people in this country who are here without papers is still going to be cost savings. And so we've got to think, as legislators, about what is ultimately the bottom line to what is safe for the rest of Americans. When we think about, COVID and infectious diseases, we can't just pretend that we're living in isolation. You and I, everyone in this room, understands the moral, need for these things. And what we have to also think about is what's in it for those who don't care. Why would they want to, do the right thing, and be able to articulate that as well, and get them to support legislation and action that ultimately helps, like you said, healthcare systems that, if they're designed for the most vulnerable, they work for everyone.
Mm-hmm. Especially when you think about also public funding, right? Sometimes we don't think about saving costs when you're using something that's public, right? I mean, and I think this is very important. Like, how can we convince all the investment that a government does on health can be translated in a healthy community, right? Or a community that's is good to live in, right? We have this combination. Sometimes we think the government and the private sector is the same thing. No, right? Ethically, government is to share resources, right? So government, we elect to share resources, to have a society that's fair. And how can we make that investment that is to the good, right? Or to well distributed. So I think those are the discussions that we have in terms of how can we promote this idea that living in a society that people feel secure for everyone is better, right?
Yes,
that those
exactly.
Disparities make all of us unhealthy, right? I think the pandemic is a good example of that, right? We got locked because we couldn't have everybody having access at the same time, right? Or even access to be at home, right? Some people could not stay home. They had to work, and that work was the driven of the pandemic, right? We didn't have, so this comes to some of the questions that we have, Rodrigo. I don't know if we can.
Yeah, we have 2 questions. I think the first one reads as follows. Can someone from the panel please exemplify beyond the numbers and percentages how the discrimination, racism, language, and cultural barriers have made diabetes widespread and so harmful among disadvantaged communities? So how did we get here, that it's such a disproportionate condition among Black and Brown communities in this country?
Yeah, if we cannot use in numbers or percentage, we can tell stories, right? And I think we've been doing that too, right? With this partnership, trying to see the numbers, but also to see the difference between healthcare settings, right? And what each healthcare settings. I think when we think about poverty, right? We're talking about this, right? Poverty is what really makes things different. And I think a lot of the theories that divide us to justify poverty. So we have to think about that. Like how many times we decide that another that's not us does not deserve the same thing that we're having access. So this is pretty much how we let some people to die, right? We can say that we necessarily don't kill people, or the system don't kill people, but the system let people die. And these people who are led to die are the people who are considered different, or that deserve that, or didn't do their best. So I think that is a way that would answer that question. Like what, when we think there is a fair distribution of resources, and we want some groups, the part, right? Monica said about 2 parts of the US. There is a part of West who wants to concentrate all the resource in one hand, right? And there is another part that wants to make this resource available, so we would have in a fair, just world. So I would see that if we don't have more ethical and moral discussion about distribution of resource and stop using wrong theories, right, or wrong assumptions to divide us, we would have a hard time being the biggest part of this part of the country. I don't know, Monica, if you agree with me.
Yeah, so that's what structural racism is unequal access to goods and services and opportunities based on race. And many of those goods and services and opportunities are things that help you become healthier, like a job where you can get insurance, like health insurance, like living in a neighborhood where there are places to exercise and green space. And so we know that even if you don't use that green space, just looking at that green space helps reduce your heart rate and helps you have better mental health and physical health. Whereas looking at crime is stressful and, causes other kinds of problems. The other thing we know is that experiencing racism, experiencing discrimination is stressful. It's like being chased by a lion in the Serengeti. All that chronic stress, is good if you're running from a lion in the Serengeti. It's not good to be walking around your neighborhood all hyped up like that all the time, afraid that you're going to get shot or afraid that someone's going to, whatever. And that causes changes in our biology that can predispose us to things like heart disease and diabetes. And so there's so many ways that racism can act to increase our risk of health problems. The list is long, but there are many mechanisms that can get you from being a regular healthy person to a very unhealthy person, just because of the way that you are treated because of your brown or Black skin.
Thank you so much. And I think we might have time for just one brief question. And I think this ties with everything we're saying to the physiological effects and the importance of access with a system that is not responsive. So what are the consequences for a person if they stop receiving insulins because they don't have the economic resources or because of not having health insurance?
Yeah. Yeah. Then we have also this incredible situation where a person is deprived of what we know could save, right, their life or could have their life. That's another we're thinking a lot of our campaign here, right? Salud Sin Barreras is to talk about that, right? I mean, we need to make sure all the technology that we have available and all the incredibly, how humanity has created so many ways for us to live longer, right? I mean, 100 years ago, we didn't have insulin, right? If you had diabetes, that's it. And special type 1, that's something that kids have. So you would have a huge problem. So I think we have to make sure everyone who can prevent or manage any kind of disease could have access to the information and the resources, right? I mean, we are talking about this. It's incredibly wrong that someone, because they don't have health insurance, stop having access to a life-saving medication. I mean, I'm not a doctor. Maybe Monica has something else to say.
Yes. So I would say two things. If you're on insulin and can no longer afford it and you're not taking it, that means your blood sugars are going to go up. Your diabetes will not be well controlled. You'll eventually start feeling bad and having complications. And if you don't have type 1, and if you have type 1 diabetes, you'll eventually end up in the hospital or die at home. You cannot live without insulin if you have type 1 diabetes. If you have type 2 diabetes, you'll eventually end up in the hospital. But there are alternative medications that you can take. And so if the question is there something else for me that may be more affordable because I don't have insurance? The answer is yes. The answer is also that many of these insurance companies have special programs for people who can get their insulin for free for 30 days, for 60 days, for 90 days, and then you can reapply. There are always workarounds. Now, they make you work for them. That's why they're called workarounds. But there are ways of accessing your insulin if you don't have insurance. And so you can do it directly with your healthcare provider or go online. But if you are taking insulin and have stopped and are not doing anything else, your blood sugars will start to rise and your diabetes will go out of control.
Yes, let's try to find solutions that not be like this. Whenever I ask this question, let's see if we can put our network to work to help to, right? To find that, find the information to deal with that.
So thank you so much for this space for Q&A. I think, Suyana, if you want to provide some wrap up the conversation, since we're approaching the end of the time.
Yeah, well, we have to end this. So I feel so privileged that we had Monica and Bessie with us today. So I think Catalina, Rodrigo, and I can speak for them. We're so thankful that you two join us today. I think for me it was so impactful. I had some remarks about empathy, but what else is empathy than us crying here, right? When we listen, this is empathy. And I think when we talk about, I was, when working on my remarks to end this, I was trying to connect this idea of healthcare as a human right. That was a slogan that La Clínica had from the beginning that even made me very attracted to work at La Clínica, to a memory of me starting my work in Brazil with low-income youth and having to deal with the fact that because they live in a low-income, in a favela, how we call those communities in Brazil, and they were young and they were Black, they were considered dangerous and irresponsible. No matter how creative, engaged, active they were, the world would see them as something that would not go right. So I remember this young couple getting to me and says, she was pregnant, she had a positive pregnancy test, and she went to the hospital and they treated the couple horrible. I mean, they pretty much said, how you dare to have a kid, being poor, being Black, being young, what you're going to do? So they come to us, this community health center that we had, and they said, I left the hospital completely lost. Still pregnant, right? Because this is the problem, the stigma, the harassment, don't make the problem disappear. Right. You just create a second problem. So then we have a young couple not feeling guided to deal with something that can even be another stressor in their life, that stress that they have. And we know that unwanted pregnancy and moral harassment are preventable things, right? People having access to information, have access to services, we can prevent that. We have many, many, many examples where young people can be on there fully and experience everything that they can do and not be targeted and not be harassed. And that reminds me, because moving to US, in some point, I become an immigrant. So this idea of a human right has to become also related to displaced population, right? When you're like a white person in your country helping the poor Black, then you go to another country and you go to see a doctor and you don't speak the language. Mm-hmm. And that doctor does not explain your health problem to you. And then you feel very discriminated because you could not understand the language, you are treated as someone who are a problem, a danger, or an invader. Then I become the couple. Suddenly, I become the couple in Brazil. So the migration makes us understand that, right? Discrimination is something that prevents you to learn what you have to do. I also felt lost leaving that appointment. I could not understand my disease. And I was there at the same, like, the space that we don't know the next step, right? For me, it was easier than that young couple in Brazil. I hope I could help them too, and I think I hoped in some ways. But for me, it was easier here because I could learn the language and I could find a job and I could have insurance. And then I could tell the doctors what I needed and find a good provider too. But not everybody have that, right? And you that are listening us now and participate on this dialogue is what I think I need you to understand. We need to make sure all of us can have access to healthcare. And that's why La Clínica is launching this campaign, because we want that you understand that we cannot say that only our behavior is going to make us healthy. Only eating well, exercise, meditating. All of us cannot only do that, because some of us has not, as Monica said, some people cannot go and walk on the park because they feel so stressed because somebody's going to harass them, somebody's going to go after them. They are afraid of the public space. They are afraid of being judged or being discriminated. So we need you to join us in a way and try to. I think we're putting our campaign website on the chat. So click there if you're listening to us now. Help us to make sure healthcare is a human right, not a privilege. Help us to explain that low-income immigrants face exclusion from accessing healthcare services to their immigration status or employment. I think also we need you to spread the word that immigrant communities deserve permanent access to healthcare without barriers. Bessie told us, like, when you have healthcare and then you don't have healthcare, this is not good when you have a chronic disease. You have to have healthcare all the time. Yes. And the way that we are trying to do that is launching this campaign. So we want to educate people. We want to educate stakeholders. We want to educate public policy policymakers. And I think what we need now is you helping us, one, to help us to explain how important it is to eliminate barriers to healthcare. DC Alliance should not be a barrier, should not have barrier there. And Betsy said about something as like specialty care, right? Because we need two things now. We need access, annually recertification, and expand access to specialty care. Because if not, some of the components of healthcare get completely broken. The referrals get broken. And we are in Prince George too, so we need in Prince George County more access. I mean, we don't have alliance there, and we need some. And we have some seed programs there. But we need more. So it would be great if you could join us, following our campaign and spreading the word. And remember, the empathy is all we need, right? Monica and I cry here today because we can hear people. We can hear people. What we need is that you hear people around you. Do not judge. Go on their shoes, right? Try to feel what they feel. And if you are doing that, and if you get emotional about it, we can change this together. So this is my final remarks to invite you who are a listener to join us. And again, Monica, thank you so much for your wisdom, but more than anything, for your empathy. I think you have some people thank you on the chat too, how much you can help us today. Thank you so much. I'd like to also say thank you to Lina backstage. Thank you to the 2 interpreters that are doing interpretation on the Zoom, and Michelle, that's our volunteer who is helping facilitating the conversation at Zoom. Thank you, everyone who make this possible. And you, Rodrigo, of course, right?
Thank you.
Thank you, Rodrigo.